Sarah, we just have to let our viewers know about the upcoming World Anemia Awareness Day,
a global anemia-a-thon.
This will be the largest anemia and iron deficiency event in history. I love that all of us joining the Anemia-a-thon will raise our hands for blood health. You know how much I love getting my hands up and unlocking my dance moves.
And we'll be helping to kick off the Anemia-a-thon at the MyPBM conference.
And along with a very exciting team of global leaders on blood health.
And our hands will be up, possibly with a cup of coffee. Anyone and everyone who cares about blood health will be joining.
So don't miss it. The sign-up form is below.
Before we get started with our amazing guest, I would like to highlight some medical terminology that will be discussed and define it for you. First, the difference between autologous blood and allogeneic blood. Autologous blood refers to the collection and reinfusion of the patient's own blood, while allogeneic blood refers to blood or blood products derived from a donor and dispensed from a blood bank. Secondly, the term cell salvage is a medical term that relates to the process of collecting, washing, filtering, and returning autologous blood or the patient's own blood back to the patient. Lastly, PPH or postpartum hemorrhage refers to excessive bleeding occurring after delivery in the labor and delivery setting. I hope you find our conversation as engaging as we did. Enjoy.
Hi, everyone, wherever you're joining us from. We want to welcome you to today's conversation. And also, we have a request that wherever you're from and you're listening to us, take a moment, if you would, after you listen to the episode and just drop us a line. I'll give you our email address. It's hello@letstalkpbm.com. We just love to hear from people and where they're from. It just warms our hearts, and we'd love to have the opportunity to meet you and actually even return your response and say hello and thank you for listening to us. And that's kind of how we found our guest today. He kept appearing on social media, and he had our lovely t-shirt. So heartwarming, and it would pop up. And there he is again, all the way from Australia. Look, this guy from Australia is wearing our t-shirt. We've got to meet him. So we'd love to meet you as well. Bernd Froessler, thank you and welcome to our podcast.
Welcome.
Thank you very much. Thank you. Thanks for having me.
I met Bernd in Bologna, Italy at Nata, and it was so nice to meet you in person. It's really special to meet someone face to face. There's something completely different about that.
Yeah, thank you. No, likewise. I mean, Nata has been quite a regular meeting for me, well, pretty much since the organization started. Often, obviously, I mean, Nata is mainly sort of Europe-based, at least the meetings are, which was always a nice opportunity for me also to see my family back in Germany. Apart from that sort of private aspect, it's I think it's a great meeting, and it's organized and run by a great bunch of people. I think every time there's a lot of learnings and there's additions to the team, and I think for me it's a bit of a given, and I certainly will be back in Munich in 2025.
Great. So you said that you're from Germany, and where are you now?
I've been living in Australia for quite some time, actually, all up almost 25 years. I came here as a medical student and did my medical rotation, actually, my final year, 87. I met Michaela, my wife, and then we lived a lot of time in Germany and in Holland during my specialist training and her university years. So we've been a little bit ping-ponging between the continents, but I started here in Australia in Adelaide as a staff specialist in 1997. That was then interrupted briefly when I went back to Germany to the University of Aachen, but we've been back in Australia since 2001. That's kind of my Australian story.
That's incredible. Wow. And how did you get started in patient blood management?
It's interesting. I mean, my training, anesthetic training, I started in 1989, and in the early 90s, I was working at a sort of fairly large teaching hospital in Germany, in Solingen, close to Cologne, and it's a teaching hospital at the University of Cologne. And I think on the back of, HIV crisis in the 80s, but also generally the knowledge or the increasing or growing knowledge around transfusion-related adverse events, we already in the early 90s had quite an autologous blood setup for major surgery. We had a lot of orthopedic surgery. So we had autologous donation, so pre-donation and plasmapheresis with frozen autologous FFP for all patients that came from major joints in the early 90s. And then that combined with the utilization of cell salvage, it worked really well. And when from memory, and I didn't have the academic interest at the time during my training, I was focusing on becoming a specialist. We rarely transfused patients apart from their autologous products with allogeneic blood products during those major surgeries. When I came to Australia, for me, initially it was also kind of a transfusion-related event that triggered my drive to look into what we're actually doing and how we can potentially change practice. When a 21-year-old came to theatre from ED after a post-tonsillectomy bleed and had a unit of red cells running when he came to theatre. Anyway, the bloods had been taken, or blood tests had been taken, but there was no result. However, without that unit being completed, the hemoglobin was 121. It was a clear indication that the ED team panicked, and I get that the patient dropped the blood pressure with the vasovagal when he felt nauseated and vomited. However, it just illustrated how we tend to grab the unit of red cells as a universal way of dealing with emergencies or hemorrhage. So we just looked at how we actually transfusing patients, but because I'm an anesthetist and the elective space is our main area where we work in, we looked at transfusion practice for our elective surgical patients. And the results showed that the patients came way too anemic into their procedures. That was kind of when I thought, now there's something not right here. That became my focus. So I started to dig a little bit deeper and then got the opportunity to visit Englewood in New Jersey. And, their setup, and already in the early 2000s, they had a full-blown, patient blood management program. And I was very privileged to then meet Arya Shander and actually at the time also Shannon Farmer and Axel Hoffman, who happened to be there during my visit. So that was very inspirational.
Some probably long-term friendships you made.
Yeah.
On that initial visit.
Absolutely, yes.
So you took that knowledge from Englewood and the SABM conference. What did you do with it when you got back to Australia? Did it change your practice at all?
It certainly did. I mean, it changed. Firstly, it illustrated to me that there is a need to look closer why these patients are anemic, and also to question why the anemic patients would actually be allowed to go ahead with surgery. And of course, sometimes that's inevitable, but in most elective scenarios, it's not. But I then questioned, and also having learned a lot about the underlying reasons why patients become anemic, and we did a little pilot in a cohort that's traditionally a little bit emotionally loaded, of course, for the patient in the colorectal cancer space. We do know that they're obviously a risk group for iron deficiency and iron deficiency anemia, but then also that there is quite a drive to operate on these patients immediately. That's often the patient's desire, but also often the surgeon's prerogative to go in as soon as possible. So there was often, when we then discussed patients with the surgeons, where we felt that there was a way of modifying the anemia or treating it, that there was reluctance to delay even by a short period of time. So what we did, we just took a few patients and had a small case series where we knew patients were iron deficient and quite anemic, where we then gave them intravenous iron and saw that all these patients responded very, very well to the treatment, made up for or increased their red cell mass and increased their hemoglobin to the day of surgery. All those 4 patients were within 12 days of surgery. That illustrated that there is clearly something in it, and that we have an obligation when we know about this, that we also have to offer the patient that treatment modality.
12 days is not long to wait to send them into a procedure much safer and with the ability to recover. I also liked the point you made too about the 21-year-old and the ED, because I think every time we see bleeding, we do panic a little bit. And I think that there is a perception that, oh, they're losing fluid, so we just replace the fluid that they're losing.
Right.
But we aren't vehicles, right? It's not like my oil has gone down a little bit, I'll just add a little more oil fluid. There's much more risk, and there's much better science behind allowing the body to regenerate its own blood back.
Excellent point. Patient blood management, again, it should be really patient focused, and we should be figuring out what's actually happening with the patient. That was a good analogy, Sarah. One aspect that we talk about often with Australia's patient blood management programs is your protocols in OB. Can you tell us a little bit more about the guidelines you currently have in place for OB for moms and babies?
As you know, the Australian National Blood Authority has been actually very proactive for the last 20 years to drive patient blood management. We were the first to release patient blood management guidelines in 2012. And then there were all the modules, and I think in 2016, the obstetric and gynecology guidelines were released. This was all backed up by a couple of projects. In 2008, there was a project called Blood Measures, and that was chaired and run by James Isbister, and it was facilitated through the National Blood Authority and the Australian Commission of Safety and Quality in Healthcare. That at the time looked at obviously a way of collecting reliable data where fresh blood components were used and what the indications were, because we all knew that we would, in many cases, over-transfuse or transfuse inappropriately or unnecessarily. So in obstetrics, we also did a trial at our hospital, oral versus IV at the time, and that also helped us to interpret the data better and to facilitate our own hospital protocol, which is in line with the patient blood management guidelines, that we ideally should try and identify those women. As you know, for many decades, for women in pregnancy, it was only hemoglobin that was assessed. And only once these women became anemic that some clinicians would look further or then put the patient on iron, because we know there's a greater need for iron in pregnancy. Still, to this day, not universal. And we found in our trial much more significant increase in hemoglobin. What we did in this trial also, and what we also did later in an abdominal surgical trial, is it's very important to take the postpartum or post-operative period into account. We often manage these patients preoperatively, but then there is obviously the surgical blood loss or the blood loss during delivery. There's also the hospital-acquired anemia that we often see. And with all that blood, we lose iron, or the patient loses iron. I thought that it was really important to focus a little bit on that time after the procedure and to not drop the ball and follow up those patients adequately.
And what were the results?
Well, we found in that study, that was a randomized control trial, we also randomized patients postpartum, again, that the patients who received intravenous iron responded better. We all know that oral iron works, but it also has a lot of adverse events, and some patients are really reluctant to take it or can't take it because of the side effects. Nevertheless, we try and send that message that it is a safe and affordable drug to start with, and to also allow the patient to a trial on oral iron. I mean, this is obviously more labor intensive because you need follow up, you have to have another blood test and have to make sure that the
Right.
patient's responding. But oral iron is still first line. There is an increasing evidence, and it's not small, that the actual treating iron deficiency or severe iron deficiency anemia, you can reliably achieve with intravenous iron, but that doesn't necessarily mean we should throw it at everyone. We still have to be selective, and we still have to give it to the right patient. And if we have the right diagnostics, we also know that that patient will respond.
Very good. Are you utilizing cell salvage in labor and delivery in Australia?
Yes, we do. That was another eye-opener for me after having trained in a country where cell salvage was very established and it was run by the anesthetic team. So when I arrived in Australia and at my hospital, there was no cell salvage available. That was something that we then started to implement. Initially, I found a bit of funding to train all our anesthetic nursing staff to be competent in this procedure, and also to take away that sort of scare factor. People would say, well, is this safe? How
Right.
can this be done? We had everyone trained, and that actually has been really successful. So it's a fairly established modality at our hospital, and we have it available 24/7. So at any time, and to me, it's particularly important that cell salvage is available in an emergency scenario, because it can also bridge that gap should you require banked products, but it can still bridge that gap, and it can, in some cases, result in a complete avoidance of banked products, or at least in a minimization. So in obstetrics, we use it selectively. So we have certain criteria where we feel it should be done. We also have a very good working relationship with our obstetricians here, because they often flag to us the patient is at a high risk of a postpartum hemorrhage. There's really good communication, and often they ask for it. In a study we did during the pandemic, we mandated cell salvage because blood services from around the world were obviously under pressure. We felt that we wanted to make sure that cell salvage was available for every patient, and we compared that to the previous couple of months where cell salvage was selected. What we found there was that we had a significant decrease in postpartum anemia, and as a little side note, we actually had a statistically significant reduction in postpartum iron infusion.
So let me just back up a little bit here for our listeners. Cell salvage, that's when we know that the best blood for the patient is the patient's own blood, right? So cell salvage is when the patient, and I'm really simplifying this, the patient's bleeding, we collect that blood and we spin it around and give it back to them. That's really excellent. And I like your point that the training, because especially in an emergency, if everybody's comfortable with that, I've heard of stories like this before. Cell salvage, it's so scary and nobody wants to use it and they're not really ready for it. But if you're using it on a regular basis, it's in an emergency, you could just use it and give that patient back their own blood, which is the best blood for them, instead of the blood from the blood bank.
A roadblock that I've seen often in organizations is, well, we don't have enough staff that knows how to run the cell salvage. A lot of times we have very limited staff. Sometimes it's just the perfusion team. So I love how you have utilized nurses, surgical nurses, and made that widely available so that everyone can benefit from having their own blood back versus foreign blood from someone else. And I think it's fantastic. We always think of cell salvage as possibly reducing the amount of blood that we use, but it can also reduce the amount of IV iron that we're
Yeah.
giving. I think that's the first time I've heard that as a result. So that's pretty fascinating.
Yeah, I agree. I mean, to us, that was kind of, well, not surprising, but it does make sense, because firstly, I want to really briefly come back to our anesthetic nursing staff or anesthetic assistants. I think what's really important is that the whole crew all of a sudden had this sort of sense of ownership, they would often initiate it because everybody's different and some people are more passionate about things than others. Often, if we particularly had new trainees, new anesthetists, would give them a nudge and say, well, have you thought about cell salvage? Our cell saver in obstetrics is a piece of furniture. It just lives there. So we actually can set this up in 2 minutes, and I think that's a huge benefit. And also often you can come in, if you didn't set it up because you didn't suspect anything, it's equally quick if you can then capture some of that blood, but maybe not all of it because you hadn't set it up in the first place. Coming back to your point of the postoperative IV iron, IV iron I think it's important to recognize that if the woman is still iron deficient, she obviously needs treatment.
Right.
Yes.
However, the iron infusion postpartum is often a response to a large PPH. If there are significant postpartum hemorrhages and the woman is profoundly anemic, it can be a very effective treatment modality because women make up hemoglobin very quickly. We've illustrated that on many occasions, even if they're severely anemic with hemoglobins in between 50 and 70. What it does illustrate that we only collected the data postoperatively, what had happened, but it took away the pressure for the treating team to be proactive, to do something
Right.
to make the patient better. In the first place, you're buying time, but then also it leaves you with the option of then sending a non-anemic or less anemic woman home on some oral iron, which then also requires follow-up.
Absolutely. Another thing that I admire about Australia is the use of the general practitioner, or we call it the primary care physician here in the United States. I think we're lagging a little bit behind you as a nation, but what role do you see for that primary care physician or that general practitioner in managing the blood health of the patient?
It's an enormous role. What's important, and in South Australia, I must say, there's been an organization called Blood Save, and Blood Save looks at patient blood management modalities. This was really driven for many, many years here by a hematologist, Dr. Catherine Robinson, who also was pivotal in sort of getting me to do this project first up. There was always a point of involving the primary care physician because they refer the patient often. If it's an elective scenario, so we kept going back to the GPs and educating them around iron deficiency anemia, and the preparation, so optimization prior to surgery, and sort of would call. In Australia, we have very long wait lists for surgery, particularly if it's elective joint replacements or arthroplasties. You sometimes have to wait for 2, 3 or more years. So we try to call them not wait lists, but optimization lists, where you have that ability to actually do something that will benefit the patient and get them to a much better starting position and allow a better recovery. What we did is we did quite a bit of GP education. This hasn't been easy, and it has also dropped off a little bit. Obviously, during COVID, everything dropped off. But
Right.
I think there's a much greater understanding. And I think the champion in Australia in GP land is, if I can call it that, is a GP from Western Australia, Dr. Pradeep Jayasuriya, and he is very passionate about this. And he's been doing infusion clinics in the GP setting for a very long time. And probably is the GP in Australia with the greatest experience and has been also educating on this. There is, of course, with almost like everything, there is a problem. I think one of the problem is the funding structure. If you want to do intravenous iron in your primary care practice, iron is on PBS in Australia, so Pharmaceutical Benefit Scheme, and is quite affordable to the patient. However, the procedure still needs to be charged and billed for by the GP because they do invest time, they use obviously materials, and there is no clear rule and regulation. So in Australia, currently, there is no item number for a very clear-cut that can be charged and also for the patient to be aware of. So it's become a little bit of a strange landscape where some GPs or GP clinics realize that this is quite a nice money earner because it's a popular modality and it's an effective modality. I know for sure and it's a personal story from a mother whose daughter was quite profoundly iron deficient and would not respond to oral treatment. The rate to be able to get an iron infusion varied from $150 to over $400. So I think to have a broader implementation in primary care, it would help if the regulator would come to the party and say,
Yeah.
oh, well, we can provide you with adequate reimbursement for this procedure. And I assume that would lead to an increased uptake.
Yeah.
Yeah.
So you are a professor. Where do you teach?
Well, I'm an affiliate. So I'm a clinical professor with the University of Adelaide. I'm not a clinical academic. The teaching really is limited to teaching registrars, to teaching outside of our hospital. Like, for example, only a couple of weeks ago, I spoke at a forum for general practitioners, so primary care physicians. We do teach medical students or university students, but when they come through our institution, that's as far as my teaching goes. It's pretty much limited to the hospital. One nice link or teaching opportunity I've had in the past was a nice collaboration with the Malaysian Society of Anesthesiologists. They had me on a couple of times on their second part course for their specialist trainees to talk on patient blood management, and it was a very nice experience, and I've enjoyed that.
Malaysia's doing a lot with patient blood management. Very exciting.
They are.
My point in asking where you teach or how you teach is I'm encouraged that the next generation of physicians are being taught. Is it in their medical curriculum now? Is patient blood management a part of their university education, or do they get that when they come to you in the hospital?
No, that has changed. And this is where Catherine Robinson was also very pivotal. In South Australia, it certainly has become part of the curriculum. But there is a lot of teaching in that respect. At our hospital, for example, every new intern intake every year in January, we have a fixed slot from our department to educate the new interns on patient blood management. And I know, for example, in our obstetric unit, but also in our colorectal team, there is a lot of emphasis on the importance and what's required to have a broad and successful implementation. So I think teaching is done reasonably well, but I agree with you. I think it should be universally, it should be part of the curriculum.
So much that we could emulate and copy you on, and hopefully we will continue to follow in your footsteps. Sounds like Germany as well. They're very ahead of the game. I'm impressed that even back in the 90s, they were doing a lot of autologous and cell salvage.
Yeah.
Yeah,
so very impressive. Shout out to them too. And I hope to join you in Germany this year. I'm really looking forward to meeting you in person.
That would be very nice. So you're planning to go?
I'm planning to go. You can razz me if you don't see me there. It is my hope. It would be my first Nata, so that would be very special.
Yeah.
As far as the takeaway for our audience, a lot of them are medically trained. A lot of them are patients. Do you have any takeaway that you'd like to share with them?
I think what's important is to ask questions. I think a well-informed patient will often ask very good questions. And sadly, often for me, contact with patients preoperatively is obviously our pre-admission clinic, and time is always a factor. I encourage patients to ask questions, and I think what patients need to be aware of is that they can look also after themselves, that it's also their role to have, blood health has become a term, but that they know what's going on and that they also know what risks they are exposed to if they're not in good health. So there is some shared responsibility here.
Sure.
There's obviously a lot of educational material out there, and I can only now quote the book, Bloodworks, which is initially written for the patient, but it's a very evidence-based book, and I can only congratulate the area and Irvin and Shannon for getting this off the ground. I think it's an amazing piece of work. And so to the patients, I can really say only to encourage them to ask as many questions as they can, because often clinicians don't also volunteer everything that's potentially there, and not blaming anyone, which is often a time issue. And maybe also to have a think about it before you go in, write things down, because once you're all of a sudden sitting in front of the physician, a lot of things drop. So similar to us today, you sort of think, oh God, what are you going to talk about? And all of a sudden things just slip your mind, but they do come back. If you have it written down, I think it's a very good starting point.
It was such a pleasure talking with you today.
Thank you.
Thank you. Likewise. I hope I managed to get something valuable across, and there's a lot more to do in patient blood management.